Okay, welcome to my presentation. This is Bridget, and I'm doing inflammation. I'm also doing stages of healing because I did not realize that was two separate categories. So what the heck is inflammation? This is the innate defense of the body, the response to tissue damage or invasion. So it's there to protect you and to prepare the body for tissue repair. It's activated by histamine release, which is usually coming out of mast cells. And it can be a result of physical injury, invasion by foreign bodies, hormonal changes, or autoimmune activity. People tend to want to stop inflammation. Inflammation is actually a good thing. It means your body is protecting you and it's healing. So what we want to do is control the effects of it. Signs and symptoms, we've got the heat coming from that increased blood flow, as well as the redness, those red blood cells. We've got swelling as things move out of the capillaries and into the tissue area, things begin to swell up. And then we've also got that pain. When certain chemicals are released, they stimulate those nociceptors. More on that in a moment. Sometimes we also have loss of function, depending on the location and degree of the injury. And you might also have some itching, some clotting, some pus formation. All of that is normal. Sometimes it can be hard to tell the difference between a local infection or inflammation. Local infections often come with fever, and you do not want a massage if they have an infection. So just keep that in mind. So the stages of inflammation, we've got vasodilation and increased blood vessel permeability. The blood vessels get bigger and they let things move through them. This entire list of chemicals and cells pretty much do one of three things. They encourage phagocytic emigration, so they call over the phagocytes. They cause you pain by stimulating the nociceptors, or they reinforce that continued vasodilation and capillary permeability. They keep that happening. So antibodies, phagocytes, they're there to take care of those foreign invaders, right? Like they want to take care of pathogens. And they're also going to help to clean up some cellular debris. Your clotting chemicals, that's going to be what helps you to form a clot. So your thrombocytes or your platelets. You've got histamine, again, released from those mast cells, which reinforces that vasodilation and permeability. The bradykinins and kinins, which stimulate the nociceptors, also attract phagocytes, increase vasodilation and permeability. And you got the prostaglandins. So they intensify the pain in the kinins. They also intensify histamine. So that tells you that they are probably also going to increase vasodilation and permeability. And then they also stimulate phagocytes to migrate to the area. Your leukotrienes come from your basophils, which are a type of granular leukocyte. They also increase that permeability, attract the phagocytes, help them to adhere to pathogens. And then you've got your complement system. So it stimulates more histamine release, it attracts those neutrophils, it promotes the phagocytosis. It helps to destroy bacteria, destroy cell membranes, which stimulates the production of more leukotrienes, and destroys mast cells, which causes more histamine release. So again, it's really those three things. Phagocytes, increased permeability, and vasodilation, and pain, except for your clotting factors. So the second stage of inflammation is phagocytic emigration. So these are the killers and the cleanup crew are coming out now. They've heard the call from the other chemicals or cells, and they're coming to do their job, which is to ingest damaged cells, cell parts, and pathogens. Neutrophils are one of your phagocytes, so those are your granular leukocytes, or one of the other ones. You've got your basophils and your eosinophils as well in that category, but just the neutrophils are phagocytes. And then you've got your monocytes, which are a type of agranular leukocyte. So after those monocytes leave the blood vessels, they actually become wandering macrophages, and they stimulate your fixed macrophages to assist in this process. And then your dead phagocytes and your damaged tissue together form pus. So that's where that symptom of inflammation is coming from. We've got a diagram here, so you can see on that left-hand side, they've got that first initial damage to the tissue, histamine's being released. And then you can see in the second picture that there's been some dilation and increased permeability. And then in that third picture, even more things are starting to move out of that cell. And then in that last picture, you're just seeing the actual phagocytes engulf either cellular debris or pathogen. So that final stage of inflammation is tissue repair. And it actually has 3 stages as well, which we refer to as the 3 stages of healing. So this is the second part of this presentation. This is the stages of healing part, which is intrinsically linked to inflammation since it's the 3rd stage. So it makes sense to have these all in the same presentation. So quick little overview, and then we'll get into how you treat in depth. In your acute stage, that's your inflammatory reaction, right? So vascular changes, chemicals moving around, clotting's happening, phagocytosis, early fibroblast activity. The subacute, things are proliferating. So we've got capillary beds forming, collagen forming, damaged tissue is being filled in, and then that noxious stimuli is being removed because it's that effects of inflammation are starting to slow down. We want the body to start to like mellow out. And then finally in that chronic stage, the collagen or the connective tissue begins to mature, that scar tissue contracts, the scar can be remodeled as the collagen lines up according to lines of stress. So just be aware these stages may not be linear. You're going to need to reassess your patient at every session because in a perfect world, it would just be acute, subacute, chronic, boom, boom, boom. But I find what happens is people tend to get to the subacute stage and they're feeling better and they overdo it, and often they end up back in the acute stage. So good patient education helps with that. So a little more about the acute stage. It's also called the protective phase because you want to be careful with the area, or the inflammatory phase. It lasts 4 to 6 days. It really sets in about 24 to 48 hours after injury, depending on the degree and severity of the injury. And you know that you're in the acute stage because it hurts before you even do anything, right? So it hurts it hurts before tissue resistance, but lots of times, if it's a severe injury, it just hurts when you're sitting there. There's a ton of heat, edema, redness. There might be some muscle spasming to protect the area. So our intent here is to control the effects of inflammation. We want to keep those healthy tissues functioning normally, stop them from becoming weak or adhering to things, and we want to facilitate wound healing. So we do that by educating our clients. So they're going to want to RICE for 1 to 2 days, rest, ice, compression, elevation. They can be doing active range of motion in the pain-free range if they have one. If they don't have a pain-free range, they should not be doing active range of motion. You want to encourage them to use other areas of the body if they can. So like if they've got an upper extremity problem, they should still be going for walks. If they've got a lower extremity issue or something else happening, then that might not be possible, or they might be able to get an ambulation aid. You might have to have a little chat about nutrition, because the better their nutrition is, the better they're going to heal. And then you want to let them know what's coming up in the next phases. So like what can they expect? Because it's scary to get injured and to not know what's happening. So what we can do as therapists is some goading over the site without a passive stretch. So we can do reciprocal inhibition. We can do massage work above the injury. We want to keep that circulation happening and, help get things moving in that area. Lymphatic work, this would be similar, the same idea. We can also do passive range of motion and muscle setting in the pain-free range. I like to get my client to show me their pain-free range. I don't want to guess. I'm not in their body, and I can't feel their pain. And then finally, when we get to thermal therapy, we want to use ice. Ice or cold here. So ice is really excellent for numbing pain, especially when you can't quite get on top of it with painkillers. So they can use also cold water or ice bath, depending on, like where the injury is. So moving into the subacute stage, this is also called the proliferative stage. and it's 10 days to 6 weeks after the acute stage. So we know we're here because there's pain at tissue resistance, and there's generally quite a bit less heat, edema, and redness. So those signs and symptoms of inflammation should be beginning to decrease in the beginning of this, and they should be pretty much gone by the end. Our intent in this stage is to promote healing. We want to help the forming scar tissue to be mobile and to lay down along that proper fiber direction. And then we also need to monitor our own treatment and our patient to make sure that we aren't overdoing it. And then you want to educate your patient about what they can do and the signs and symptoms of doing too much. So treatment-wise, as therapists, we can use any extrinsic treatment here with reduced pressure though. So you're going to be cautious. You're going to work within the tissue and pain tolerance of your client, and you want to follow up with ice. Again, we have reciprocal inhibition. Local cross-fibering can be done, but you want to save that for the later subacute stage where you start to move into tissue maturation. There's that slight overlap with the chronic phase. Pardon me, and then you would ice after again. General cross-fibering can be really nice to do along the tendons and ligaments. IFMS can be done on the tendon to reduce muscle tone. And then again, muscle setting. So just a quick reminder, these are isometric contractions that you do for under 7 seconds, and you do them at multiple angles in the available range of motion. So these are very different from the isometric muscle energy techniques we use to decrease hypertonicity when we work with dysfunction. The intention here is actually the opposite. We're trying to recruit muscle fibers and strengthen things. And then especially in that later subacute stage, that'll help to encourage that collagen to lay down along the line of pull. Again, you need to stay within your client's pain tolerance, right? You need to be in that pain-free range of motion, which should be considerably bigger in the subacute stage, or at least within a reasonable degree of pain. So your clients, you're either going to set them up or you're going to send them to someone who knows more about X-rehab than you. This is the point where they want to be starting some resisted range of motion and some stretching. So you're going to have to educate them on what exactly to do. And this should be progressive. So as they get better through this stage, because it can last, 10 days to 6 weeks, they should be increasing the difficulty of what they're doing. And then finally, thermal therapy for this, you want to use contrast. You can alternate hot and cold packs or hot and cold baths, again, depending on the location of the injury. So, and then we've come to the chronic stage of healing. So this is known as the maturation phase. Sometimes it's called the post-acute phase, which is super confusing because the subacute phase should be post-acute. It's after the acute phase. And it's also known as the return to function phase. So that tells you a lot right there. There's going to be little to no signs of inflammation. So that heat, that edema, that redness, it should almost all be gone. Theoretically, there should be none, but because again it has that slight overlap with the late subacute stage, there could be a little bit. Where exactly do you draw the line, right? So just be aware that days 21 to 60 after the initial injury, there's the potential you'll already be in the chronic stage, and this is a really important time period because there are lots of fibroblasts around and things are easily remodeled. You know that you're in the chronic stage because there's pain on overpressure. So that's usually a result of adhesions and contractures. Our intent here is to increase flexibility and strength, especially like of the damaged tissues, and especially line of pull strength. We want to stress that maturing tissue in a safe way so that we can make this happen by using any and all of our extrinsic and intrinsic techniques. So that's not actually how we're going to, well, intrinsics you might stretch the tissue for. But we're going to use local cross-fibering. We want to break down any collagen cross bridges and encourage alignment of those fibers along the line of pull and along the line of the existing healthy tissue. And then again, you're going to follow that with ice, right? Because you created inflammation. You're going to progress the stretching and the strengthening exercises that you've given to your client. So again, we want to increase that strength of the tissue. We want to increase the range of motion. We want to increase the endurance. And we want to get that maturing collagen really strong and lined up in the proper directions. We want a strong, well-aligned scar. Patient education, you're going to have to talk to them about like how to progress with each of these exercises or stretches that they're doing, signs when they're doing too much, which you should already have talked to them about in the subacute stage, and then like what caused this injury? Do they need to make some kind of change to how they're doing things at work or with their hobby, or like do they trip over their doormat every day and finally they just fell down the stairs one day and maybe it's time for a new doormat, or to just throw that thing in the trash, right? Because we want to prevent this from happening again. And then finally, again, we've come to thermal therapy. So we want to use heat in the chronic stage. Moist heat goes deeper, so that's a consideration. And then we also want to use castor oil to increase that like mobility of the scar. So castor oil and heat generally are combined. You apply a castor oil pack, you put heat on top of it, you wait 10 to 15 minutes, and then you can do some scar work. So you can have your patient do that at home, and you can also show them how to move that scar around fascially. So not friction, but that just gently moving of the skin almost in every direction. So, medications for inflammation. We've got over-the-counter NSAIDs, prescription NSAIDs, prescription steroidal anti-inflammatory drugs. Sometimes they're oral. Usually over-the-counter NSAIDs are oral. Sometimes they're topical, so you can get a steroid cream. And sometimes it's an injection, like cortisone. So these all work by interfering with the production of pro-inflammatory chemicals, and they decrease pain perception. So what does that say right away? For treatment, it's masking pain and the signs and symptoms of inflammation. So we need to be cautious. Like the tissue is not going to show the effects of our work to us, and the patient isn't going to be able to give reliable feedback because their ability to feel pain has been numbed out a little bit. So if someone's on a drug long term, it's something they take all the time and they're not coming off of it, try to schedule your massages when the drug is at its lowest activity. This will let your client and their tissue give you the most accurate feedback. Be aware also that some of these medications can cause thinning of the skin and an increased risk of tearing, so be careful in any thin areas, and if they have open sores, do not massage over them. The other thing that comes with those steroidal anti-inflammatory drugs tends to be a compromised ability to recover from tissue damage. So you're kind of stopping the inflammation process, which means you're stopping the healing process. So people who are on drugs like that, you're going to have to treatment plan more towards relaxation probably and stress reduction. And even if they have a dysfunction, now is not the time you can work on that because their body just doesn't have the capacity to repair the tissue you're going to break down. Yeah, so that's everything. All of this information came from our 2 textbooks or PowerPoints from Dale or Sheila or notes I took in class discussions. And then I just wanted to finish. I know Sheila wants us to end our year sprinting. Some of us, like myself, may be in a condition where we've just climbed out of a hole, and I'm not particularly able to sprint, but what I can do is crawl. So if you're like me and all you can do is crawl, just start crawling, at least you're moving. So thank you for watching this presentation. It's been a pleasure and a privilege to educate you, and I hope you have a lovely day.